recovering CIO, having been a Chief Information Officer. I'm sure there's a few of you in the room. For several leading healthcare organizations in the Northeast, including Boston Medical Center's Health Net Plan, Senior Whole Health, and sorry, a call came through on my phone I had to get rid of. Lovely technology. Of New York and Massachusetts, and other health plans. Mary is currently a lecturer at Northeastern University and University of Connecticut and a management consultant. I would also add she's a mentor and past president of New England HIMS, an incredible foodie, and if you're ever out to eat with her, her palate will not serve you wrong. And she's also a wonderful mom and grandmother, so she's the whole package. So we're really blessed to have her at New England HIMS, because I don't know what we'd do without her leadership and mentorship. So anyway, I want to welcome her and to the moderation of this panel, and then I also wanted to introduce one of our sponsors from Echo Store, Mike Johnson, to come up and explain a little bit about your company and also introduce the rest of the panel. Thank you.
Is it on? Thank you. Is it on okay? Yes. The dreaded post-lunch presentation. Congratulations. My name is Mike Wilson. I am the Chief Strategy Advisor for Echo Store for healthcare. And basically, Echo Store works with about 25 significant technology partners to have those technologies work together in order to store, deliver, and secure patient data. It's a very simple message, and what we want to do is to make sure that we get the best spend out of all our technology spend in order to solve our patient storing, delivering, securing issues. I am happy to introduce, when we get a chance, stop by, we'll tell you how we do that, and at the same time, put your card in there in order to win some Red Sox tickets. First presenter here is Michael Gagnon. Michael is currently the Chief Technology Officer for Vermont Information Technology Leaders, also known as VITAL for those from the Vermont, and it is a statewide HIE. Mike will be starting off, and then second to that will be Jeffrey Loughlin. Jeffrey is the Executive Director of the New Hampshire Health Information Organization. I think we say NEO. Do we say NEO? Yeah, I thought so. And then finally, we have Dr. Heyman, and Dr. Heyman has quite a long list of significant accomplishments. Currently, he is the Chief Medical Information Officer for Whittier IPA. Have that right? And they operate the Wellport Health Information Exchange. And I believe, Mike, you're going to start off with a presentation.
Very good. Thank you.
Thank you.
Can you hear me?
Yes.
Very good. I'll hopefully not put any of you to sleep after the lunch. And if you were at the March New England HIMS conference in Worcester, you'll see some repeating information here. But for those who don't know, VITAL has been around for quite some time, about 12 years. Myself and the current CEO of VITAL were some of the first ones to start the organization when we saw that interoperability and health information exchange was going to be an important part of the healthcare system in Vermont. And we had some incredible leadership there in Vermont early on that recognized that this was probably going to benefit payers and others quite a bit. And so one of the interesting funding mechanisms we had was that they instituted a tax on claims, as Michael Costa was saying earlier. And that's pretty unusual in the health HIE world. But that tax on claims is like 0.0199% that funds something called an HIT fund. And that HIT fund is then used as state Medicaid dollars to draw down federal funds. And so that's both been, I will say, about a blessing and a curse to some degree. For us, it's sustained us for quite a while and allowed us to do many things, and we'll talk a little bit about them here in just a second. But we have a 14-member board. We have a staff of just over 30. I said state grant is for continuing operations. We're hoping this year to change our grant to a contract. sounds like something small, but it's a big difference in terms of grants and contracts. A grant, basically, if you spend $1, you get $1. And with a contract, you provide services and are paid for those services. And so basically, we were not allowed to make a margin. So how do you run an organization without any margin? It's pretty challenging. We were state innovation model state and had significant funding there, and it pushed ahead several projects for us in the last few years. We have some commercial agreements with healthcare organizations, and specifically with the largest ACO in the state called OneCare-Vermont. We have a large contract with them to provide data services for them, and I'll briefly show you what some of those are. That's our vision, and we think we're well on our way to doing that. And you know, this is kind of, we view our role in the healthcare reform initiatives in the state is to be that data provider that allows others to do much of the work on the ground with actually the clinical work. We have every Vermont hospital connected, plus Dartmouth, Hitchcock, and a few others. So and the real difference between Vital and many others is we have really deep penetration into our marketplace. Nearly all the primary care providers, many specialists, home health, and many other agencies are already connected into our network, which means, you know, there's not much left for us to go. There's still nursing homes and others, but we've made a long, deep penetration in there, and that's kind of unusual. If you look at many other states, and we regularly compare ourselves to other states in terms of health information exchange, it's pretty rare to be that deeply penetrated into your market, and it gives us a tremendous opportunity to look at that data in a way that other organizations simply, you know, cannot, because they, you know, usually you start with hospitals, right, with the big data generators. But when the time you get to that, you know, like little medical practice running the CHR, you know, granted the cost effectiveness starts to vary at that point, but it does provide valuable information. I think we're well over 5 million clinical messages a month now, and this is the kind of data we get, you know, from all of them, and we provide most of the immunizations to the Vermont Department of Health for their immunization registry. So a little over 2 years ago, we said we need to build this into a clinical data warehouse. You can't just have, you know, a big data repository. Let providers look at that data in a provider portal and think that that's the, you know, wave of the future. Clearly, information technology doesn't go that way. You start out with that way, perhaps operationalizing system, but eventually you want to use that data for more important purposes like population health and others. And so we started building a clinical data warehouse collected from all the data we collect into the VHI. This was an interesting challenge. Data quality varies greatly, as you can imagine, from organization to organization. And we use the terms as complete, accurate, and consistent over time. And so if it's not complete, there's not much we can do about it other than work with the provider to make it complete. If it's not accurate, there's many things we can do about it. We can try to do terminology normalization. We can try to do natural language processing. We can try to do data quality cleansing, or at the very least we can provide a dashboard of reports back to them to tell them how well they're doing. And so we kind of embarked on this mission of improving the data quality so that not necessarily for us to be the analytics provider, but let the ACO provide their own analytics, so let the healthcare organization provide their own, or let the patient-centered medical home provide their own. But we were going to give them a clean data set that they could work from, that had, you know, mapped the patients across all the different areas with a master patient index, and then cleanse that data for their use. So I felt like that was kind of our role in this, is to be the health data managers. And so kind of what we see on the right-hand side here is what we built. I don't know if there's a... Oh. Problem.
Oh, there you go.
Are you looking for a pointer?
Yeah, it was a gear pointer.
That's powerful.
Just go back ahead. So, yeah. Red dot shows up. So when we first started, the Vital started at the same time the Vermont Blueprint for Health started, which is an interestingly drove us to do providers at the small clinicians and primary care docs first, as opposed to doing hospital data first, which was really interesting and a unique challenge, and made us really, really, really learn what a CCD is, and what it is not. And so, because those two things grew up at the same time, we initially were just we just pressed transactions through our system, and we didn't do anything else with them. We never even aggregated them. And so, because this kind of function, this blueprint for health, grew up at the same time, we kind of focused differently, and it at first was kind of a real challenge because we didn't have the hospital data, but over time, it's been a real benefit because now we really understand CCDs extremely well. And then, about 3 years ago, OneCareVermont was formed, and as Michael Costa was talking about earlier, they're now kind of our all-payer ACO, and so we provide all the data to them now, at least all their clinical data. So we created a gateway, and a gateway is just tell me all the patients that are in your population, and I'll filter out everybody else, and I'll put all the patients in a repository so that you can then use your own analytics to do things. And they have their own analytics vendor, and we just kind of push the data down to a data mart for them. And that was another thing we were able to do. So we've put in our own integration engine, our own master patient index, terminology services, and soon natural language processing. We'll be able to extract clinical measures out of textual reports. Probably the biggest thing we've done, and the one that probably is the most innovative thing, is that we completely parsed every CCD message down to their individual data elements by every vendor. And if you know anything about that, every vendor has a different format of these things, and they're all over the place, and they're extremely hierarchical. And it's all XML, but we wrote a bunch of parsers to take that stuff all apart, and so that we can have now a clinical repository that has individual data elements. And so it's really allowed us to do a tremendous amount of data that we could not do before. And then we developed some quality reports that tell you how well you're doing in terms of the quality measures for ACOs and the blueprint and others. And we're just about to rolling them out to individual provider organizations to kind of give them a scorecard to their quality. Because this is not a kind of you do this lightly or on your own. This is a gigantic feedback loop. Providers think they're doing a great job, and often are, but the data they provide you don't always reflect that. Or if it's in claims, it's really old. And so we wanted to give them something that was a lot quicker feedback about how well they're doing in terms of are they meeting the quality measures? Are they coding this stuff right? Is it coded to national standards? Is it complete? And so, this feedback loop we thought was really important to make this whole thing work. So I guess we'll save questions to the end. Thank you.
Can you hear? Yes, you can hear me. Hi, I'm Joe Heyman, and Wellport, that's our website, so that's wellporthealth.net if you're interested in exploring it. And as you can see, it's owned and operated by something called the Whittier IPA. For those of you who don't know what an IPA is, it's an independent practice association for physicians who predominantly wish to remain independent and not be, I won't call them the slaves, but will not be the employees of some large network or some hospital. And the Whittier IPA is unusual in that it owns a health information exchange. We've been working on it for a long time. It started in August of 2014. And I'm just going to show it to you briefly on some slides. Oh, first of all, I have to tell you that what I'm going to show you is HIPAA compliant. My mother-in-law is the most famous patient in Massachusetts. She's 94 years old, sorry, 98 years old.
Wow.
So this is her demographics up here. This is a date line, and it actually goes back about 5 years. Everything starting here are future appointments that she has with somebody in our community. So, for example, she's going to North Shore Internal Medicine on April 10th, and her podiatrist on April 25th, and she's got some lab work due on May 9th at Anna Jake's Hospital. This is a hospital visit, which she's already had on March 7th. Podiatry visit, ENT visit, endocrine visit, Anna Jake's again, North Shore Internal Medicine again. And these little boxes that you see are all progress notes of some kind. So at Anna Jake's, this would be a consultation note, this would be her emergency department visit, and these are progress notes from individual practices. And what's different about this is that when you open the note, you actually see the note. You don't see a CCD. You see the complete note. And we get this from about 7 different EMRs. Some are only capable of giving us a CCD, but from most practices, we get the complete note. In addition, on the same timeline, you can see when she has lab work. You can see the individual results, but if you need to see the reference ranges and the actual report, you can see that. We get the information from 6 different laboratories. Also, there's a section right here, you can move from section to section. This is her administrative summary, and what's great about this is you can see the information that's coming from each of the practices that are feeding her EMR. In her case, there are 11 different ones that are feeding her EMR. So if you're a doctor in practice and you send a bill and they say that her insurance number is wrong or something else is wrong, you've got 9 other practices you can look at the same numbers on and make sure that you've got it correct. Also, this is her clinical summary. The meds, the allergies, sensitivities, alerts, immunizations are all here in one place. And in addition to that, we are connected to the Massachusetts Highway, which is the Mass HIE, which basically is just secure messaging. But we're connected to it, so we each have our own direct address from Wellport, and we can send information to, for example, a consultant at BI Deaconess, and if we're lucky, they might once in a while open their email and actually see what we're sending them. And so that's an additional functionality that we have. So the advantages of an IPA ownership are that physicians are traditionally the people who actually care for patients' medical records. And in this case, we are indeed the stewards for the entire community. We have a code of ethics about how they're supposed to be used. We have instantaneous access to aggregated data. There's no physician imprisonment. If a person changes from one EMR to another EMR, they don't have to worry about whether they can get their data out of the old EMR because it's always there on the HIE, and it's complete data. It's not just the CCD. Also, if they leave one practice and go to another practice, or if they leave a hospital employment and come to us, in any event, their information is always available to them, and their patient's information is always available. It's also a potential income stream for the IPA. We charge the hospital in our community as one of our customers, as are all of our physician subscribers, the nursing homes, the home health groups, and they do produce a little income for the IPA. And as I mentioned, we all have private direct addresses. The advantages of a regional HIE is, especially in Massachusetts, we've got these huge networks. We have the Beth Israel Deaconess Network, which our IPA for the next 40 years is a part of. Stewart Healthcare Network, there's the Leahy Tufts Network, and there is the Partners Healthcare Network. But patients who live in the northern part of Massachusetts don't know whether their doctor is a Partners doctor or a Leahy doctor or a Beth Israel doctor. They're all just doctors in the community. And the beautiful thing about this is we don't just see Beth Israel Deaconess patients. We don't see just Partners patients. Every patient in the community has their record available through this thing. So there are no silos. It improves the health of the entire community as well as the efficiency. There's ease of referrals, and we have a single patient portal for the entire community. So you can talk to any of your doctors who are part of this, and also you can see your clinical records from everywhere. You don't have to go to individual portals. The long-term advantage of this regional HIE is quality measurement for the entire community, quality measurement for any subset, and the potential addition of new innovative services, some of which we may not even know yet. Where are we now? We're 2 years into it. Well, actually 3 years into it now. We have 9,000 clinicians and their employees on the platform. We have 400,000 patients in the system. In 2016, there were 45 million transactions. We have only 18,000 patients opted in. And that is because Massachusetts is an opt-in state, and it's very difficult to find the resources to get patients opted in. If we offer them a consent, 97% of them join. The problem is finding somebody to offer them that consent, and then the processing of those forms after they've signed them is costly and a nuisance. And so my biggest job over the next year is getting the law changed so that we become an opt-out state. And anybody here from Massachusetts who wants to be an ally in that endeavor, just let me know. We have 2 nursing homes, 2 home health agencies, 1 behavioral health organization, 1 hospital, 6 labs, and the entire medical community of Greater Newburyport. The 2 people who use this the most are 2 nurse managers that work for the IPA. They actually, as every patient is discharged from the hospital, if they're a chronic disease patient, they get a phone call. They look and see when their future appointments are. They call them to remind them to go to those appointments. They check on them to make sure they're taking their meds, etc., so that our quality measures for the Beth Israel Deaconess Network are the 2nd highest in the network, higher than their academic group that's down in Boston. We have an iPhone application which does some social media and also has all the same information that's on the portal for the patients. And we have an iWatch application that's coming up. And our biggest challenges, I said, were the opt-ins, getting paid physicians to sign off the notes, although we finally solved that problem by just giving them 2 weeks to sign off the note. If they don't sign it off in 2 weeks, we take the note anyway, even though they didn't sign it off. And sometimes they put their structured data in some very unusual places, and we're unable to find that data when we want to do quality measures. I was asked, because of my association with the AMA, to give you a different aspect from Chicago than the one we heard earlier today. So I just wanted to let you know that the AMA is very optimistic about IT right now. Because of the Cures Act, we feel that there's room now for genuine trust infrastructure for health information exchange, that there is definitely an interest in established HIEs rather than trying to replace everybody with one single HIE. The AMA is very proud of its making sure that Sequoia and Commonwealth didn't compete with each other, and it pushed for their unification and collaboration. They are very happy with the ONC attitude, which seems to be learning rather than imposing, reducing the IT burden on physicians and on EMRs, which may be why vendors are not paying as much attention as they were paying before. And the requirements and penalties for data blocking are very, very good as far as the AMA is concerned, for all three kinds of data blocking, whether they're technical, financial, or contractual. And this is my information, and thank you very much for listening.
Great. I'm Jeff Loughlin. I have the pleasure of serving as Executive Director for NEO, the New Hampshire Health Information Organization. Who's from New Hampshire here, real quick? Okay, both sides this time. So I've learned over the years that New Hampshire likes to do things differently. And it's important to understand when we say HIE, there is not one single term. More often than not, and two great examples here of successful static HIEs. Organizations that aggregate data and use it for all kinds of great purposes, population health, all the great things that both Joe and Mike just mentioned. Like Massachusetts, that Dr. Heyman alluded to, New Hampshire is really just a transport HIE only. So we move data, we don't aggregate data. That decision was made about 5 years ago when NEO first started. It was a conscious decision by the organizations that came to the table to build the plan for the HIE. And just to make sure we didn't go too much further, the state jumped in and said, by the way, you cannot store data. So even though New Hampshire's got a lot of great ideas and wants to move forward, we are very limited by what the state will allow us to do. So specifically, you can see here, NEO, although we are the statewide organization, are not allowed to store data in any capacity. So we focus on secure messaging, using the direct standards, as many now, that's really now called the HIS, the Health Information Service Provider, which is really what NEO has focused on. What we've seen over the last 2 years, as organizations like Direct Trust have come in and established all of those relationships, there's about 14 HIS vendors now running in New Hampshire. They're all connected, and Direct Trust has kind of solved that problem. We used to do manual contracts, manual connections. That's now kind of taken over by Direct Trust. You got organizations like Care Quality, Commonwealth, doing both. They push notifications like Direct and now Query and Retrieve through organizations in both of those. So the need, at least in New Hampshire, for that centralized repository is really starting to dissipate because you can solve a lot of the same problems of getting the data that you need by organizations like this. So over the last, I'd say the last couple of years, again, we're about 5 years old. We've actually only provided technical service for the last 4 in New Hampshire. We started to look at all these major components of interoperability because that's where we focus our attention. Moving data and interoperability between those data organizations, EHRs. When you kind of run down the list of cost and complexity of some of these major items, a lot of it has been taken over by the market. E-prescribing is done by SureScripts. Lab vendors have monopolized the market on lab results delivery. Moving down to some of the more resource intensive, Query and Retrieve, Commonwealth starting to solve that solution, and the law says I can't be an aggregator. So we're kind of limited here in the middle to moving data. So focusing on some of these more advanced services, where we are in the marketplace right now, take a kind of sidestep. NEO, unlike a lot of other states, we only received $5 million from the feds to build our HIE. So with that being said, we did a lot of great good with a very minimal amount of money. So we don't feel like we overspent your tax dollars or mine, and we built a good network. But what we did is catalyze the market. And rightly so, the market has taken over New Hampshire, and we feel good about that because that's what the original ONC grants were designed to do. So we're now at the bottom now. We're trying to figure out our role moving forward because although we don't provide a whole lot of technical services anymore, we have a valuable role as an advocate for behavioral health, LTPAC communities, the folks that we just talked about, a little bit earlier. The struggle being, going back to the survey that Rob showed us, HIE, if any of you saw it, you probably couldn't see it because it was down here at the bottom of the screen. HIE is not an imperative for providers, so we're trying to figure out kind of where we fit, into that model right now. For those of you that use our services, we are disconnecting a number of our services. Right now, about half the hospitals use us for public health reporting, for electronic lab and syndromic surveillance. We're discontinuing that service, at the end of this year. For a couple of hospitals, Dartmouth, being one of our big ones, and a couple others, primarily that use Epic as their EHR, we're discontinuing services for those guys also at the end of this year. So most likely what we'll see is organizations like SureScripts or Relay Health or UpDocs coming in and taking over those services. Where we are expanding is the use of webmail, especially when you think about the LTPAC, the behavioral health. A lot of them do have EHRs, but they're very new organizations or they're new EHRs. A lot of times this technology hasn't been built into their product. They may not have been certified, or they have been certified, and it's way too cost prohibitive to buy that in that module. We're coming in with a very low-cost solution to keep them in that technology space. We've partnered with an organization called Collective Medical Technologies. They will be providing a statewide event notification service for all of New Hampshire. Right now, that's kind of baked into the district funding for the Medicaid waiver, for those that are familiar with that. But that should be implemented very soon. And we've also partnered with TigerText and Improvisa's Cortext for provider secure texting. So we have all the pieces and parts to notify the providers, notify the patients, and to get the data that you need. We just don't keep it all in one spot, anymore. And with that, I'm looking forward to some questions.
Okay, we've had 3 very different perspectives on HIE, and we just wanted to ask some questions of the panel. And now that we see your different approaches, I think you all would say something's either working or it's not. So what are the challenges that you've had, and what do you think is the greatest value to your communities right now?
Well, I'll just start with questions just because I have a microphone. I think the challenge, obviously, in the case of transport only, and I can speak a little bit on behalf of Massachusetts as well, is that we're seeing that the market has really taken over a lot of those services. I think having the statewide perspective has been really good in terms of opt-out, opt-in, consent procedures. But when we think about healthcare in general, organizations like Partners, BI, Steward, they don't care about state lines. They're moving across organizations. You already mentioned Dartmouth is across 2 different state lines, and neither do patients. I was talking to a gentleman in the back who lives in southern New Hampshire and takes his kids to Children's Hospital. Why wouldn't you do that? You want to go where you can and get the best care. So the state lines are starting to be eroded from the patient perspective and more from the data perspective. So organizations like mine that simply move data need to focus on moving that data across larger platforms like SureScripts or nationally based vendors versus local state-based vendors.
So one major, well, as I mentioned, we have 400,000 patient records. We have only 18,000 of those patients opted in. And that is a major problem for us. And the Mass Highway and the Massachusetts government knows that it's a problem because they just changed the Mass Highway from an opt-in to an opt-out. But when they published the regs, they excluded anybody except for the Mass Highway, which is why I'm trying to change the law. Another big barrier is not having single sign-on, so that every physician can receive this information within their EMR. Most physicians would like that. I would say the people who use our HIE the most are not physicians. They're either people who work in the physician's offices, or they're people who work in the nursing homes or the home health organizations, and the patients. Patients use it to look up their lab work or their radiology reports. So I would say those are our biggest barriers. The other barrier for us was a political one. it took a long time for the hospital to finally give in and join because it didn't own and control the HIE, which it thought that it should do because that's what happens in most communities.
So I have my own microphone, I guess. I won't drop it, okay. So just like Joe, we have the same kind of issue with the fact that we're also an opt-in state. We have like 1.8 to 1.9 million unique patients in our master patient index, interestingly in a state of only 600,000 or so, and probably have maybe 70,000 or so, maybe a little bit more, who've actually opted in. So like, maybe 10% of our population, and it's growing because we've got UVM Medical Center finally on board with starting to collect consents here, and that'll start to grow quickly, but it's a real challenge. I mean, you get into the record and you just can't see a large, you can see 90% of the people are blocked from view. That's not a positive thing for most of them. Interestingly, it was a real challenge. I've seen this thing emerge over the entire time that it's happened, and it was just a challenge to get people to send their data in the first place. And so, being 10 years old and think of this being, 8 years ago, there was a very different mindset about the sharing of data. Now that we're talking about value-based care, that has completely flipped around. And so, so one of the other challenges we have is that because our agreements are so old for our data use agreements with our provider organizations, they don't yet allow us to take even de-identified data and to share it back with people. And so because of that, we can't really compare to populations unless we get either a healthcare organization to say, yes, all my data can go to this repository, or if we get a patient to sign a specialized authorization for their data to go into some kind of repository. So that's how we get around our ACO, is that we get the patients to sign something that says, yes, I'm a member of this ACO, and that's how they get in. So that's another interesting challenge of ours.
The way we handle that challenge is that we have a business associate agreement with each of our subscribers that allows us to be their business associates. So we transfer the data even for the patients who haven't opted in. We transfer the data because we're acting for them as a business associate.
Yeah, we can take the data, we just can't share it back to them, even de-identified. So, but we found that the marketplace is very different nowadays, though, that people are much more willing to do care coordination. And so, just because those agreements are so old, but if you realize we've got about 300 of them out there we've got to go fix. And so that's not going to be quick, right? So we want to go back and kind of redo our data use agreements because we're not finding much resistance to the de-identified use. We're just hamstrung by our own old inertia of those policies, and so that's part of it. And then what was Rob was up here and said, that was really interesting to Rob and I. From Rob's our VP of marketing at Vital, that the provider organizations just aren't thinking ahead in terms of health information exchange and those other things where the vendors are. That was really telling because that's exactly what we find too, is that the marketplace just seems to be in denial that this value-based thing is going to ever happen. And we're shocked by that, but that's kind of where we are. They're just kind of not really moving along. They're still complaining about their EHRs, basically, right? They don't work right, and that's the problem du jour, And so that means we need to be ready, but not also making huge investments yet until the marketplace is kind of ready to say, oh yeah, we need you to be there. And we find that we're often way ahead of the curve in terms of this stuff, and that's both a good thing and a bad thing, right? If we don't pick right and you're way ahead of the curve, then you've kind of done the wrong products. But if you kind of got the core correct, then when they're ready to say, oh wow, MIPS is really coming, I guess I have to do something about it, you'll be ready to hit that ground and run with it.
So if we go to the patients, and Joe, I had a question for you. What percentage of the transactions that you had last year were from patients as opposed to providers?
Well, I don't know that answer, but I can tell you my impression, which would be probably 4%, 3%, something like that, 5%. I think patients don't use it unless they are looking something up. If they've had a lab test, they might use it. I would say, of all the patients we invite to join, we send them an email as soon as they sign up and consent. I would say only about 10%, 15% at the most actually sign up for the board.
So let's take New Hampshire. Was there any view from the patient perspective of what an HIE was or what the communities expected the HIE to do?
Sort of. So I think we did, at least so we do have a 17-member board of directors. And from the onset, a patient advocate role was designated as one of the seats on the board. And we've continued to fill that. At one point, the board makeup actually changed and that position was lost for whatever reason. But the board has continued to fill that role, and actually our patient advocate is here today in the audience. So I think as a board, we've done our due diligence in making sure the patient's perspective was taken into account. The challenge is when you're just talking about moving data, we're moving data using the direct standards. That standard hasn't really gotten down to the patient level yet. So there's no real tools readily available on the market for patients yet. I think obviously accessing a repository of data is a great way to go, and the different APIs, so you can access that using tools to action that data versus view it, but not having that data, there isn't much we could do at this point.
Mike, any input on that?
Yeah, we actually tried to consider a statewide patient portal because we kind of realized that one of the fundamental problems with having provider-based patient portals is that they're organization-centric, not patient-centric. And so that means it would have been nice, but by the time we were ready to go, the meaningful use rules were so far along, and we really think they got that one really wrong. That having portals by vendor, by org, just means that if you see more than one org or more than one portal, what's the value of that as a patient, right? I don't see value in that. And so, we kind of missed the timing of that. If we had been a little bit more ahead of it, we would have had to be way ahead of it. We might have proposed, more of a statewide at least. That's still not perfect, but at least it's better, a statewide view of that information so that you could see your care across all the settings. So we kind of missed that one. And then the second thing we have done a little bit, we started working with an organization that does kind of patient-provider texting. So they can do some secure texting back and forth with one another. And that seems to have more of let's say the patients like it because they can kind of communicate with their doctor, and if the doctor is willing to kind of work on that, work with that system, then they do communicate nicely back and forth. It's not a big portion of what we do yet. So patient engagement has not been a huge thing for us yet. We're still kind of working on the data management part of it, and we've focused more on the healthcare reform initiatives.
Okay. How do you think the new administration is going to impact all of your efforts? And I might be able to say, how do you hope that it will?
Yeah, I like the hope that it will better. Maybe they'll just get so stuck in their, in the mud that they actually won't change things too much. Because you're going to have to propose something different than ACOs or some other value-based care model, right? You're not going to just blow that off, or maybe they will. But if they do, in many ways, what we're trying to build is agnostic to whatever healthcare reform initiative you pick. If we're aggregating all this clinical information, we can figure out a way to also aggregate claims information, which is some of the questions I was asking earlier, together. And just that, to me, is a valuable resource that will be used no matter what. Someone will find that valuable because the data in there will be what drives your decision making. Data always can help drive decision making. And so it's almost like regardless of what happens at the federal or state level, we still kind of are marching down the same path because you need the data to be effective.
So a couple of things. First is that we actually started looking at developing an HIE in 2005. that was well before the ACA. It was well before any of this stuff, and anybody was even thinking about value-based care. Because it doesn't matter what the payment system is. This encourages it, more HIE, no question about it. But the fact of the matter is, you cannot have continuous good care if one doctor doesn't know what the other doctor is doing. You still need health information exchange. And the fact that it's easier to do now than it was 15 years ago is just all the better. So I don't think, no matter what the administration does, I still think we're going to need health information exchange. The second thing is that Bob Havasi mentioned that, you know, most of the people who are working in the government are the same people who were working there before. And the odds of those people changing their attitude is not that great. And as I said, the AMA is pretty optimistic because they think they're taking a new sort of more hands-off attitude than they did before. And that makes it possible for innovation. It makes it possible for physicians to stop having to do extra clicks for some third party. And so I think in all those ways, we can be pretty optimistic about the future.
Yeah, we just echo, I think, at least from a technology standpoint, the loosening of the standards, loosening of the grip is really allowing, you know, a lot of vendors to really move forward and drive the innovation, things like care quality, Commonwealth, solving a lot of those day-to-day problems. I think that the fear, though, is the unknown side is, you know, will there be funding available for the long-term care, the mental health, those organizations that were left behind, and who's going to be there to support them moving forward?
Yeah, across the entire continuum of care. Now, do we have any questions from the audience? It's after lunch, huh?
After lunch coma.
Rich.
So the New Hampshire exchange doesn't coordinate with any other exchange across state borders, or does it?
It does only in the sense that we are, you know, as I mentioned before, a HISP, a Health Information Service Provider. So
Right.
we're connected through Direct Trust, so Mass Highway can send messages to NEO, but just those direct secure messages back and forth.
Oh, okay. I was curious if you sent raw data to somebody through an exchange, it's going to be stored in the other exchange.
Yeah, we don't do that at this point.
Any other questions? Okay, I'd like to thank our panelists. Take a quick break now so you could get your coffee and get energized. We'll see you back here in a minute.